Very good afternoon for all those of you who have joined us on today's online live session on breastfeeding. So, this talk is going to be on the theme of the World Breastfeeding Week, which is observed every year from August 1 to 7. And this year's theme was Breastfeeding for All, Closing the Gaps. So, World Breastfeeding Week, as you all know, is an initiative that was started from the World Alliance for Breastfeeding Action, or WABA, and this is being observed every year across all countries in the globe from August 1 to 7 with the objective to engage all individuals and organizations to enhance collaboration and support for breastfeeding, to galvanize action on reducing inequalities in breastfeeding support, and to anchor breastfeeding as an equalizer to close gaps within the society, and to inform people about the inequalities that exist in breastfeeding support as well as prevalence. In this presentation, we shall be discussing about the breastfeeding indicators in India. We shall be discussing briefly about barriers to breastfeeding across both facilities and in communities. We shall be discussing about feeding in both healthy infants, term infants, as well as feeding in low birth weight preterm infants and some special situations. Briefly about human milk banking and the way forward. Two important statistics that come to our mind while discussing about breastfeeding is one, the early initiation of breastfeeding rate, which is the proportion of infants who are begun on breastfeeding within first 60 minutes after birth. And two, the proportion of infants who are continued on exclusive breastfeeding for 6 complete months. Now, despite various strategies and improvement in institutional births, the proportion of infants who are given early initiation of breastfeeding still remains static at 41.8% as per NFHS 5 data and has not changed much from NFHS 4 that was published almost 6 to 7 years ago. This is despite the predominant institutional births that happen across most of the places within the country. So you can see the distribution of the urban as well as rural proportions of children who were initiated on breastfeeding within first 1 hour. It remains quite dismal both in the urban as well as the rural setup, and the national average is at 41.8%. Coming to the proportion of babies who are exclusively breastfed, it is currently at 63.7% and has made some progress from the earlier NFHS 4 proportion, which was roughly 55%. So although there has been some progress on the exclusive breastfeeding rate, there has not been much progress in early initiation of breastfeeding rate across the country. That is what we understand from the NFHS data. When we look at this in the context of NMR, we can see that the neonatal mortality rate did come down from 29.5% to 25% over around 5 years from NFHS 4 to NFHS 5. And infant mortality rate has come down from 41 to 35%, 35 per 1,000 births. So although there is some decline in both neonatal and infant mortality rate, you can still see that newborn deaths contribute to a substantial proportion of infant deaths. So considering that India today is the home to the largest number of newborn births every year, roughly 25 to 26 million newborn births occur every year in the country, given that up to 64% babies are exclusively breastfed in the first 6 months, still 35% infants are deprived from the benefits of breastfeeding. So considering the large number of newborn births that we have every year, India is the home to the largest number of non-breastfed infants as per the UNICEF data. This is not a very recently updated data, but still we can see up to 7 million infants every year are non-breastfed, and this is the largest number for any country in the world. So given all the population statistics that we are dealing with, let us now move on to what we already know very well. What are the benefits of breastfeeding? We know that breastfeeding is associated with numerous advantages to the baby, to the family and community, and to the mother. The breastfeeding benefits to the baby include that it is complete food and it is species specific, it is easy to digest, and it is well absorbed. It is protective against various infections because of its immune factors, including lactoferrin, secretory immunoglobulin A, and proteins like PABA. And it also promotes emotional bonding between the mother and the infant and is conducive for better neurodevelopmental outcome because of the predominance of neuronutrients, particularly the long-chain polyunsaturated fatty acids, docosahexaenoic acid, sphingomyelins, etc., which are able to confer a better developmental quotient to the breastfeeding baby when compared to the formula-fed baby. There are numerous advantages to the mother, including earlier involution of uterus, decrease in postpartum hemorrhage, a natural contraceptive technique which helps to delay the subsequent pregnancy, and lowering in the risk of breast and ovarian cancer to the breastfed mothers. And in addition to this, it decreases mothers' workload, a very important benefit in mothers who are working or mothers who are in the community who have numerous other household responsibilities. In addition, it is also associated with lots of benefits to the family and society as a whole by being more economical, promoting family planning, and decreasing need for hospitalization, particularly for infection-related morbidities, and contributing to better child survival. These are statistics from a AAP policy statement on breastfeeding published way back in 2012 and show that breastfeeding is associated with a significant reduction in the risk of otitis media. You can see that there is 23% lower risk of developing otitis media with any breastfeeding. And if the baby has been exclusively breastfed for more than 6 months, there is a much better risk reduction by 77% for recurrent otitis media and 50% for single episode of otitis media. Similarly, there is a 60 to 77% reduction in the risk of respiratory tract infections, of 25 to 40% reduction in the risk of asthma, and a 74% risk reduction in developing RSV bronchiolitis. Similar risk reductions for other morbidities like necrotizing enterocolitis among preterm infants on human milk, risk of allergic conditions like atopic dermatitis, inflammatory bowel disease, celiac disease, obesity, type 1 and type 2 diabetes, and even lower risk of developing acute myeloid and lymphatic leukemias in breastfed babies. Among all interventions, such as the provision of appropriate complementary feeding, vaccination, zinc supplementation during infections and diarrheas, the provision of better water, sanitation, and hygiene standards, and immunization, it has been seen that exclusive breastfeeding for 6 months and continued breastfeeding up to 12 months is the single most best effective intervention to prevent childhood mortality, with 13% reduction or 13% effect on averting childhood deaths. So 1 million childhood deaths could be averted simply by this single very effective intervention. So what are the barriers that prevent the translation of this very effective intervention that we all know is beneficial into 100% translation? So what are these important barriers? Barriers are many, including the lack of appropriate information to mothers, lack of proper feeding skills, which comes from a lot of lacunae in our healthcare systems, where inability to share this information by all of us as healthcare providers, inability to provide adequate time also come in this process as hindrances in providing proper feeding skills to the mothers and their infants. Aggressive promotion of baby foods is another important issue, and lack of proper support structures both at the community level and at workplace, like maternity entitlement or adequate space and privacy for continuation of breastfeeding, all come in as important barriers of breastfeeding. So this table lists some important barriers in terms of the supply side barriers and some demand side barriers, and classifying these in 3 major headings: acceptability, availability, and accessibility. So we'll now discuss briefly about feeding in term healthy infants, where we'll try to cover the following heads: when to start feeding, how to feed, what are the good practices to support lactation, and some common challenges while breastfeeding, as well as contraindications. So it has been seen that breastfeeding is a natural and low-cost way of feeding babies and children, and this has been emphasized again in the Sustainable Development Goals, which target reduction in maternal and childhood deaths by the year 2030. It is well known that early initiation of breastfeeding is the buzzword, and breastfeeding should be started within 1 hour after birth, and this is facilitated by early skin-to-skin contact and good practices like breast crawl. When compared to infants who were initiated on early breastfeeding within 1 hour, where the risk of child death was 0.7%, there was a steep increase in mortality when initiation of breastfeeding was delayed wherein mortality increased by 1.45 times at when breastfeeding was initiated within 1 day, 2.7 times higher death when initiation of breastfeeding was delayed until day 2, and subsequently to up to 4.42 times higher mortality if breastfeeding was delayed after day 3. Breast crawl is a very encouraging strategy wherein the baby would naturally crawl towards the mother's breast while being provided skin-to-skin contact, and the temperature gradient between the mom and the baby would support mother-infant thermal identification and communication in breast crawl from birth to breastfeeding. So these are good practices that help in initiation of breastfeeding within 1 hour. Now, all of us who are working with newborns, babies, and mothers have this huge responsibility for improving this important yardstick statistic from the dismal 41.6% where it is today to a proportion where it can translate into more effective success of exclusive breastfeeding at 4 months, 6 months, and subsequently. So these are some important steps with regards to proper positioning. Of course, there are different recommended positions, including cradle, cross cradle, football hold, and lying side lying position. But the important steps to be remembered while talking about appropriate positioning are that baby's head must be in line with the body. The whole body should be well supported. Baby should be turned towards the mother, and baby's abdomen should be touching the mother's abdomen. Not only is good positioning important, but also good attachment, ensuring that baby's mouth is wide open, lower lip is everted, upper areola is more visible than the lower areola, and baby's chin touching the breast are important steps in adequate attachment. Ensuring good positioning and attachment are important for ensuring good latch, which is in turn important for ensuring the success of breastfeeding. Some important steps for enhancing prolactin secretion include early initiation of breastfeeding, good attachment and effective suckling, frequent feeding including night feeds, and effective emptying of the breast. Factors hindering the secretion of prolactin include a delayed initiation of feeding, introduction of prelacteal feeds, bottle feeding, incorrect positioning, ineffective attachment, and painful breast. So prolactin is the important hormone for milk secretion, and the other important hormone is oxytocin, which is important for milk ejection or milk letdown. Factors that enhance oxytocin secretion involve are the thought of the baby, sight or sound of the baby, and the mother being relaxed and confident. Anything hindering with these factors is likely to hinder the secretion of oxytocin. So in addition to ensuring adequate position and adequate attachment and ensuring that the mother is allowed to have adequate prolactin and oxytocin reflex, the other important challenges that need to be tackled may include addressing flat or retracted nipple, which is done by manual stretching and pulling out and by adopting syringing technique. Sore nipples can also be a hindering factor or can be a common breastfeeding challenge. This is addressed by improving poor attachment and application of hind milk, avoiding frequent washing of the nipple. Breast engorgement can be due to infrequent or ineffective feeding and can be addressed by hot fermentation, effective and frequent milk expression, and adequate breastfeeding, ensuring that the breast is emptied at each feed. Another important concern mothers often complain is about not enough milk. This is frequently because of infrequent breastfeeding, poor position and attachment, too short and rapid and hurried feeding, and breast engorgement or mastitis. Treatment is basically about addressing the cause. So try to correct the frequency of feeding, encourage more frequent feeding, especially at night feeding, provide proper attachment and positioning, take care of a painful condition or sore nipple by improving the attachment to the breast, and provide frequent back massaging for stimulating lactation and building mother's confidence. There are very few absolute contraindications for breastfeeding, almost nil, except for some metabolic conditions like galactosemia. There could be some related contraindications, such as a mother who is infected with HIV, or especially when the family opts for exclusive replacement feeding after being counseled about the AFAS criteria, which includes appropriateness, feasibility, acceptability, safety, and sustainability. Very few supplements are truly indicated or recommended on breastfeeding. And the one important supplement is vitamin D at a dose of 400 international units given daily once until 1 year of age. Iron is recommended by the AAP or American Academy of Pediatrics in exclusively breastfed infants at a dose of 1 milligram per kg per day starting from 4th month until 1 year. Feeding in the preterm low birth weight infants is a special domain when it comes to breastfeeding. And in this group, breastfeeding or early effective aggressive enteral nutrition is important not only for preventing short-term morbidities such as infections, metabolic bone disease, and to facilitate early discharge, but also for long-term gains such as improvement in subsequent growth and long-term neurodevelopmental outcomes, and improvement in the neurological outcomes, and prevention of adult onset obesity, coronary artery disease, and stroke. Challenges in breastfeeding include, in this group especially, where the demand is high and the baby may have poor feeding skills, inability to suck effectively, and to coordinate suck, swallow, as well as breathing. So based on the gestational age at birth, the first or initial mode of feeding can be ascertained. Less than 28 weeks, usually the babies would require parental nutrition for variable times. Based on the gut motility and the tolerance to enteral feeding. Between 29 to 31 weeks, sucking burst would develop, and most babies would initially need kavach feeding, either nasogastric or orogastric. Babies between 32 to 34 weeks have mature sucking efforts and can be fed with a spoon or palada, and most babies more than 34 weeks can be started on exclusive breastfeeding if hemodynamically stable. Choice of milk would always be unequivocally mother's own milk as the first choice, followed by pasteurized human donor milk in settings where appropriate milk banking is available, followed by standard or enriched infant formula, that is either term or preterm infant formula. Enteral feeding can be initiated within the first 12 to 24 hours in the majority of these babies, and there are very few absolute contraindications with the exception of intestinal obstruction. Initiating EBM at a dose of 10 to 15 ml per kg within the first 12 to 24 hours is not associated with increase in the risk of NEC, and rather can be associated with better tolerance for subsequent nutritive feeding. Nutritive feeding can be begun at a rate of 15 to 20 ml per kg in babies below 1 kg, or at a higher volume of 25 to 30 ml per kg for more mature infants, and can be initiated after 2 to 3 days of tolerance to enteral feeding in majority of these babies. The intermittent bolus feeding given at a gap of 2 to 3 hours is physiologically more sound and is recommended over continuous feeding techniques. And the frequency of feeding can be fixed between 2 hourly or 3 hourly based on the baby's initial birth weight. Most babies more than 1250 grams would be candidates for 3 hourly feeding, whereas babies who are born with birth weights less than 1250 grams may have some physiological benefits with 2 hourly feeding. In babies who have some contraindications like absent or reversed end diastolic flow, there could be some physiological rationale for keeping NPO for the first 24 to 48 hours, followed by trophic feeding. Monitoring can be facilitated by a number of techniques which are associated with almost overlapping sort of benefits. These techniques include measurement of abdominal girth, looking for vomiting, or looking for pre-feed gastric residuals, or looking for bilious or blood-stained aspirates per se. If the infant tolerates feeding well and is clinically well, one may skip monitoring each of these parameters individually, and we can only look at the abdomen clinically. If the abdomen is visibly distended or loopy, then we might start measuring the abdomen girth, and if there is increase in a girth by more than 2 centimeters from baseline, we could look at one of the other parameters like the pre-feed residuals. So this is an algorithm to manage feeding intolerance. This is a very controversial domain. If there is an increase in the abdomen girth by more than 2 centimeters from baseline or recurrent vomiting, then one could look at pre-feed residuals by aspirating the stomach contents. If the residuals are clear and are not blood-stained and not bilious, then based on the quantity of the feeding aspirate, it is classified, and then appropriate action is taken. Most of the time, if the aspirate volume is less than 50% of the feed volume, it might be quite safe to continue feeding. However, if the aspirate volume is more than 50% of the feed volume, or if it is either bilious or blood-stained, fresh blood-stained, or if there is frank bilious vomiting, then most of these babies may require variable duration of enteral fasting and appropriate evaluation in the form of an abdomen X-ray. If feeding tolerance is recurrent, one may also assess for other clinical signs of instability, and appropriate necessary action would be taken, and a surgical consultation may also need to be planned. Coming now to the role of multi-component fortification, this is recommended majority of babies who are born premature, below 32 weeks, or with a birth weight below 1500 grams, in the form of addition of 1 gram of multi-component human milk fortifier to every 25 ml of mother's milk, which is followed as per the standard fortification policy until the baby reaches a weight of 2000 or 2500 grams or term corrected gestational age. In contrast to the standard fortification policy, there are individualized approaches that are now available, targeting an appropriate blood urea nitrogen level and adjusting fortification concentration based on the BUN levels. Fortification meets most of the macro and micronutrient requirements as recommended by various nutrition or pediatric gastroenterology societies like the ESPGHAN. So as you can see in this table, giving 180 ml per kg of fortified expressed breast milk meets most of the macronutrient recommendations. For example, calorie content of 144 kilocalories per kg per day can be achieved by giving fortified mother's milk, which lies within or even greater than the ESPGHAN recommended target of 115 to 140 kilocalories per kg per day. Most of the micronutrient requirements, which cannot be met even with maximal volume of enteral intake of unfortified mother's milk, will be automatically met when we start fortification with a multi-component fortifier. So if fortification is continued as recommended until around 2000 to 2500 grams, it may not be necessary to supplement other micronutrients such as calcium, phosphorus, vitamin A, etc. But once fortification is stopped, which is typically after term gestational age or after 2000 to 2500 grams weight has been crossed, then we may have to start supplementing vitamin D and iron, at least these two, until 1 year of age in preterm, very low birth weight babies. Hence, to conclude, exclusive breastfeeding in term infants is the norm until 6 months, followed by continued breastfeeding until 2 years. Preterm infants can be fed expressed breast milk through a orogastric tube or through a palladi. Fortification is helpful for VLBW infants, although it doesn't have demonstrable long-term benefits, but it is associated with short-term benefits such as earlier weight gain and linear growth, both length and head circumference. Supplementation with vitamin D and iron might be recommended for all preterm low birth weight infants. What about special situations? Now, feeding in hypotonic infants can become challenging because of uncoordinated or weak sucking efforts and impaired pressure, frequency, and duration of sucking. But breastfeeding is still protective in this group from ear and respiratory infections and malocclusion. So a dancer's hold position is recommended in this group where the baby's chin and cheek is supported by both thumb and index finger, and as shown in this picture. A supplementary nutrition system where the baby can be latched onto the breast and baby's sucking efforts can be rewarded by drops of expressed breast milk that may be let down by a feeding tube that is taped onto the mother's breast can be very useful in infants who have weak latch and poor sucking efforts. Hypertonic infants may also be difficult to latch to the breast because they may tend to arch the body and they may overreact to stimulation and they may do too much rooting. And these infants can be managed by a kind of sling, swaddling in a blanket as demonstrated in this picture, with the knees bent as if in sitting position and the spine rounded using a sling. Another anatomical issue that may predispose to some challenges in breastfeeding would be ankyloglossia or tongue tie, where there is a sublingual frenulum connecting the tongue to the base of the mouth. This can account for almost 12.5% of all breastfeeding problems with an incidence of 3 and up to 12% in well infants. The severity can be assessed with a Hazel-Baker score, and infants who have a tongue tie and who also have challenge in breastfeeding would benefit from a frenulotomy. This can either be in the form of a thin anterior lingual frenulum or a thick posterior frenulum. This is the Hazel-Baker assessment tool for a lingual frenulum and assessment of function, and a functional score less than equal to 11 would be associated with a higher need for intervention. Another anatomical defect is cleft lip or cleft palate, where mothers would require specialized support for breastfeeding. The ability to breastfeed depends upon the size and location of the baby's cleft lip or cleft palate. For example, a large through and through unilateral cleft lip and palate may be associated with significant challenge with breastfeeding. whereas a small anteriorly located cleft palate or an isolated cleft lip may generally be associated with a higher likelihood of successful breastfeeding. Cleft lip, try to feed the baby from the side of the cleft lip, which is to be turned upward. Cross cradle or modified football hold position may be useful in feeding infants with cleft lip and palate. And the mother may try to occlude the cleft lip with her thumb and index finger. A modified football position is demonstrated in this figure. It is important to support the baby's chin as well as jaw and position the breast towards the intact side of the palate. However, in difficult cleft lips and palates where direct breastfeeding may not be possible, we may have to use a specialized special needs feeder called as a Haberman feeder, which has a special sort of slit valve which controls the flow of the feed depending upon the orientation within the baby's mouth, and has a valve membrane which kind of rewards even the weakest suck efforts from the baby. Twins, often thought to be a challenge for exclusive breastfeeding, may still be a situation where exclusive breastfeeding may be possible if the mother is taught and shown how to use football position to concurrently feed both the infants. The mother can be asked to lie nearly flat with the one baby lying next to her, and the baby's head latched onto the breast and his feet pulled close to her body, while the second baby may lie across the body with the head on the other breast and feet tucked in under the baby's knees. So this is a football position which may help mothers to feed twins concurrently. Of course, with working mothers, one may have to follow a lot of additional strategies to combine a few direct breastfeed sessions and few express breast milk sessions. And a lot of community programs have been rolled out in countries like Kenya or Vietnam with a high proportion of working mothers to make breastfeeding successful. It is very important to have advocacy here and policies wherein mothers may be able to avail paid maternity leave for at least 6 months in order to facilitate breastfeeding in this group of mothers. Human milk banking has revolutionized the way we have been able to provide human milk for high-risk babies in the NICU. So the process includes donation of milk from voluntary donors who satisfy inclusion criteria and who have been screened for viral infections using hospital grade breast pumps. Mother's milk can be expressed, pumped, and this can be initially pooled. Then this is subjected to Holder's method of pasteurization, where the milk is warmed until 62.5 degrees centigrade for 30 minutes, followed by rapid cooling, followed by deep freezing of the milk. Quality control checks are done where milk cultures are sent, and milk sample which are found to be culture negative and free of infection are subsequently deemed to be fit for dispensing, and they are thawed before being dispensed to the needy babies. So these are pictures taken from our sort of milk bank where you can see pooled milk, which is stored before pasteurization and subsequently is frozen post pasteurization, awaiting dispensing. So all over the country, we have now close to 100 milk banks, although there is a huge unmet need for human milk because of the large number of preterm infants in India. So the way forward for improving or sustaining whatever benefits, successes have been achieved in breastfeeding would be to bring in the right awareness among community by debusting some myths that exist and providing the right information to the beneficiaries, involving all the stakeholders. So this is an example of an advocacy, a policy which was made at Nilofer Hospital, wherein every baby who could not be established on early initiation of breastfeeding, there would be a stamp where the nurses and healthcare providers would be made accountable for what was the reason for early initiation of breastfeeding not being achieved in a certain mother-infant diet. Every hospital needs to develop their own internal quality improvement initiatives and devise PDSA cycles in order to improve the successful implementation of each of the necessary steps. So this is an example of a QA project, a fishbone analysis on why there are challenges in the implementation of early initiation of breastfeeding. which identifies problems such as shortage of nursing personnel, not having a written policy for early initiation, and residents and interns are not emphasizing enough on early feeding. This is an example of a QA project that was implemented in JIPMER, where there were nurses who were designated as bonding angels, whose exclusive responsibility was to initiate every baby who was delivered by cesarean section, making sure that early initiation of breastfeeding was provided by the time the mother was shifted to the ward. So this project resulted in an improvement in the success of early initiation of breastfeeding, as demonstrated in this chart here. So these QI projects and similar projects are necessary in every unit, be it a corporate sector hospital or a public sector hospital, to improve the implementation of exclusive breastfeeding as well as early initiation of breastfeeding. So in this picture, we have two important champions of breastfeeding, Dr. Alamelu ma'am from Nilofer and Dr. Keshavalu sir. Some of them have been so instrumental in improving the implementation of accreditation processes like the BPNA accreditation, which helps in sensitizing, training, and certifying health facilities as baby-friendly hospitals. The Lakshya program, which is the labor room quality improvement initiative launched by the National Health Mission in 2017, targets to achieve 80% or more breastfeeding within 1 hour of birth with at least 30% increment in baseline. So I conclude by telling that challenges are what make life interesting. Overcoming challenges is what make them meaningful, and wishing everybody who are working in mother and child domain to work more actively towards progress in exclusive breastfeeding rates. Thank you so much for your patient listening.